Hi everyone, welcome back. Today we're diving deep into a condition that often alarms parents, viral conjunctivitis caused by adenovirus. Adenoviruses are non-enveloped DNA viruses that are highly resistant in the environment. They can survive for several weeks at room temperature on contaminated surfaces, which significantly increases their infectivity. Most commonly, they cause ocular or respiratory infections, or infections of the ENT sphere. More rarely, they cause gastrointestinal or urinary infections, hepatitis, or even meningoencephalitis. These viruses are widespread worldwide and are responsible for a considerable number of infections. Humans are the only known natural reservoir. Transmission usually occurs through direct contact, either via hands or contaminated objects. They can also be transmitted through respiratory droplets or contaminated swimming pool water. The incubation period is between 5 and 12 days. Patients are usually contagious during the first 2 weeks while the virus is present in secretions. Clinically, the typical presentation is viral keratoconjunctivitis. It begins with a sudden onset of red eye, conjunctival edema, and preauricular lymphadenopathy. Patients experience a foreign body sensation, photophobia, pruritus, and tearing. There is often significant eyelid edema, which may even produce ptosis. After about 1 week, corneal involvement appears with superficial punctate keratitis. At this stage, children often develop greenish secretions, which frequently alarms parents, leading parents to believe that an antibiotic is needed after a week of illness. Importantly, this infection occurs almost exclusively in young children and only rarely in adults. If the virus affects the ENT sphere, it may present as pharyngitis or rhinitis with fever. In some rare cases, it can even progress to pneumonia. Encouragingly, after infection, a serotype-specific immunity develops. This means the patient becomes immune to that specific serotype. Reinfections are rare and usually occur in immunosuppressed patients. In extreme cases, disseminated infections can occur and may even be fatal. The standard diagnosis is PCR with detection of viral antigens from conjunctival secretions. Sampling should be vigorous to collect enough epithelial cells, though this is uncomfortable. Ideally, 2 blood samples for serology are collected at onset and 2 weeks later. Does sending these samples actually change medical management? In most cases, it does not. In the majority of cases, the infection resolves spontaneously within 2 to 3 weeks. Most cases resolve ad integrum without leaving any permanent sequelae. Importantly, there is no specific treatment, vaccine, or passive immunization. The only effective measure is strict hygiene and regular, careful hand washing. Keratoconjunctivitis remains mainly a clinical diagnosis with little relevance for further diagnostics. In these pediatric situations, it is essential not to prescribe antibiotics even if symptoms worsen. I hope this deep dive helps you manage these cases with more confidence. Don't forget to like and subscribe for more clinical insights. Thanks for watching.